few years ago, I was the chief revenue officer at Intellityx, an event tech startup that provided ticketing, entry management, and payment solutions to the biggest music festivals in the world. If you've ever been to or heard of big music festivals like Coachella, Tomorrowland, or Bonnaroo, and worn one of those RFID wristbands, that was probably our technology powering the main gates and all the payment systems. After some success, we felt like we were in a position to level up the company and really accelerate our sales and marketing efforts, so we started increasing our paid marketing. And like magic, the leads started coming in, including this email. Hi there, looking for all of your services. Would someone please reach out to me at your earliest convenience to schedule a call? It was from someone representing a new music festival set to happen in the Bahamas, and based on our research, it looked like it was going to be amazing. On the call, it sounded like it was going to be amazing. We talked about the celebrities they'd signed on as endorsers, the huge social buzz they'd created, and the $25 million they'd raised to fund it. We were excited. It sounded like exactly the type of customers that we were looking for, and we were the perfect company to provide them with the tech to make everything run smoothly. The name of the festival? Fyre Festival. That's Fyre with a Y. So Fyre Festival looked amazing, and the team organizing the festival was able to convince a lot of partners that it was going to be amazing. But it turned out to be an absolute train wreck. Everything that could be mismanaged was mismanaged. And as a result, everything that could go wrong did go wrong. I'm Eric Janssen, an entrepreneur turned sales professor, and I have a simple mission: to change the way people think about sales. Because sales is a life skill. And this is Sales Reframed, a podcast brought to you in collaboration with Ivy Executive Education. How do you sell someone on doing nothing when everything in them screams to take action? This week, cancer surgeon Dr. Bafara Day and executive coach Shaquille Barmal share why diagnosing before prescribing isn't just good sales advice. It can literally save lives. So you might be wondering, Eric, if this thing looked so good on paper, why didn't you end up working with them? Well, that's exactly what this episode is about. We're going to be talking about a winning strategy for every salesperson: how to diagnose before you prescribe. I believe the best salespeople are guides, and part of that job is to help customers make informed purchase decisions. The mistake that most salespeople make is to prescribe a solution before really knowing what the problem is, or if they're a fit, to even be able to help solve it. So how do we fix that? Simply put, you need to diagnose before you prescribe. Think of it like this. If you walk into a doctor's office and say that your knee hurts, you wouldn't expect the immediate response to be, I think we better amputate because, I've got this pretty sweet referral thing going on with the surgeon and I can make this happen for you at a big discount, but I need an answer like right now? That would be nuts and malpractice. Instead, a doctor asks questions. What were you doing around the time it started hurting? Anything new or different? They probably do a physical exam, maybe order some imaging, refer you to a physiotherapist, schedule a follow-up, and so on and so on. They diagnose. And in sales, I think we should be doing the same thing. In fact, it's precisely because we did some basic diagnosis that we were able to determine that Fyre Festival was not a partnership that we wanted to pursue. We avoided being associated with a fiasco that could have really damaged our brand by not letting our enthusiasm get the best of us, and by asking some really basic questions. What company did you hire for security? Who's doing the fences? Who are you working with on catering or hospitality? Who's leading the stage build? Their answers weren't just shaky. They didn't exist. If you're not familiar with planning an event like this is not last-minute stuff. These are the fundamentals. It became pretty obvious that these folks were far more interested in the social media buzz and celebrity cosigns than they were in the nuts and bolts of putting on an organized, safe, successful event. So yeah, we'd seen enough last-minute sprints before to know that this was going to be a disaster. So we walked away. I call this fit first selling. It's about putting the fit test before the pitch. When I interviewed positioning expert April Dunford in our episode on Unlock Your Hidden Value with Superpowers and Super Passions, she shared a story about buying a toilet. The successful salesperson was the one who listened, asked questions, and figured out April as a client before he started talking about brands, models, or anything else. You can't sell someone the right anything if you don't make sure the thing you're selling is a good fit. That means learning some basic facts before you start pitching a solution. Things like, what's the actual need or problem the customer has? What's their budget? What's their timeline? How knowledgeable are they about the alternatives? Our tendency in sales is often to go in with this bottomless well of enthusiasm for the thing that we're selling. Like, we believe that our solution is the best and it's right for everyone, and we should tell our prospect everything about it on the call. But I think that's a mistake. And in other lines of work, that mistake can mean a lot more than losing a sale.
There was, a patient that I remember very clearly. He was in his late 70s, diagnosed with a very low-risk cancer that within every prediction model would place his risk of prostate cancer mortality at under 1%. However, he had gone from surgeon to surgeon, radiation oncologist to radiation oncologist, asking for treatment. And rightfully so, every physician told him treatment won't prolong your life, but he kept searching.
That's Dr. Fyre Festival. He's a surgeon at Memorial Sloan Kettering Cancer Center in New York who cares for people with urologic cancers such as prostate cancer, kidney tumors, and bladder cancer. His team at Memorial Sloan Kettering ranked #1 in the nation for urology cancer care by U.S. News & World Report. He's a graduate of Harvard and Georgetown, and in 2024 and 2025 was named America's top doctor by Castle Connolly. It might seem like a bit of a left turn to have a surgeon on a podcast about sales, but I think there's a lot we can learn from Dr. Festival. He's a true innovator when it comes to seeing communication as a crucial part of diagnosis. So back to the story. A man in his late 70s comes to Dr. Festival's office looking for a surgeon who will treat a very low-risk prostate cancer.
When he came to me, I realized quickly that I'm no different than the other surgeons or radiation oncologists that he has already seen. My recommendation wouldn't be any different. So why is he still searching? And as we expanded the conversation beyond just treatment for cancer and prolongation of life, it became clear that what was really affecting him was waking up at night. He felt he couldn't sleep because he had to wake up 3, 4, 5 times a night to urinate. And he attributed those symptoms to his cancer, and he felt if he treated his cancers, those symptoms would go away. Of course, we know now that those symptoms are often due to just benign growth of prostate tissue, even though there may be a cancerous focus within the prostate. And oftentimes, those treatments don't improve those symptoms. In some cases, they may even worsen those symptoms. But fortunately, there are treatments for that. And so we changed the conversation, focused on his interest, explored the concept of monitoring his cancer, but more importantly, addressing his urinary symptoms. And we have an entire voiding dysfunction team at our hospital that he saw, where he initiated medications and other treatments that helped him sleep at night. And that became the best solution for him.
Curious how you framed that conversation in a different way, because this is someone who had a bunch of these conversations previously. And did you say, yes, we will get to treatment options, but before we do that, I want to allocate some time to better understand X? Like, how do you frame it so that he opened up what he wasn't doing for the other doctors that he was seeing?
In general, I think a concept that works very well is to address the issue that is perceived to be the conversation starter, which is the cancer diagnosis, and acknowledge that that would be a focus of our conversation. But before we get there, we need to have a better understanding of all aspects of him and personalizing and individualizing care to him. And all that information will go into the best treatment option. So before discussing treatment or even discussing his cancer, expanding the conversation to what was important to him, to his family. And that initial conversation changes immediately, because oftentimes when patients come, they want to hear about treatment options. And we're very good at explaining those options. So we're very comfortable with that initial conversation, just going straight to the conversation about treatments. However, taking that step back, pausing, and expanding to their interests and individualizing the care, I felt in many cases helps really introduce these other interests that patients may have.
Diagnosis before prescription. I like it. I mentioned before that Dr. Festival is an innovator when it comes to patient communication, and part of that innovation was looking outside of his field of expertise to figure out how he could help patients make better, more informed choices about treatment. For him, it started with a concept in oncology, particularly in prostate cancer treatment, called active surveillance. Basically, it means when you have a localized, slow-growing form of cancer, what prostate cancer tends to be, you don't have to rush to aggressive treatments the way that you would with other forms of cancer. These treatments often have really serious side effects, which can have a huge impact on a patient's quality of life. As an alternative, you might do active surveillance. You monitor the cancer closely through different forms of testing, and you only treat if there are signs of growth. It sounds like a win-win. But 10 years ago, when doctors were beginning to advocate for it, it was a hard sell for a lot of patients. And that's because often what the doctors thought they were saying wasn't what the patients were hearing.
When someone's diagnosed with cancer, the C word is really a call to action. And for patients to then hear from their physician that the best course of action is, in fact, to not do any surgery, not do any radiation or treatment. That required a different frame in regards to both the reference, but also a different conversation. And that's what really started us exploring adapting some of these techniques in behavioral psychology in explaining risk. In studies actually, surveying patients after conversations about this approach were quoted as saying or understanding it as being do nothing. So that was one of the big challenges for us to tackle and really disengage the concept that active surveillance is do nothing and reframe it as a treatment for prostate cancer like any other intervention studied as a separate arm in a clinical trial with other interventions with an outcome that's very favorable.
Early on, when you were advising the active surveillance approach, what percentage of patients were actually following that guidance or following that advice before you stepped in to reevaluate how to approach it?
Some of the larger studies conducted looking at practices in the United States, really for men who were eligible for active surveillance, the acceptance rate was less than 30%. At our center, again, we were early adopters. Innovation and leadership in prostate cancer management has been very critical at Sloan Kettering for now 3 decades of incredible innovation and leadership. We had achieved about 70 to 80% of patients eligible for active surveillance were choosing active surveillance. Our goal was to not only expand that at our own center, but try to expand it nationally and to understand one aspect of the acceptance of active surveillance is really the patient-physician communication.
So how did that lead you from those patient conversations to meeting Professor Malhotra?
Like many people, you take a lot of things that happen at work and you bring it home and you discuss it and you discuss your challenges and your wins and losses at work. And I was in those conversations with my wife and she is a business graduate, went to an MBA program. And as we've discussed, this concept to her was very similar to this idea of negotiation. And through her help and later speaking to one of my research mentors, Andrew Vickers, we narrowed our focus to really finding the world's experts in negotiation theory and behavioral psychology, really finding excellent communicators and understanding if our hypothesis could be tested. And so that was the real point in which we found and reached out to Professor Malhotra.
Did you actually cold call him? How did you get in touch with him?
I had friends who were at HBS who may have provided me his email, but I basically asked for a brief phone call. He was kind enough to return my email and give me the opportunity to speak to him on the phone. And as you mentioned before, I used that as my opportunity for my elevator or 30-second pitch to help him understand that this is an opportunity that could impact hundreds of thousands of men who are diagnosed with low-risk prostate cancer. And I think that moment, he obviously had the foresight and intuition to realize there is an opportunity here to make an impact.
I think you did something really uncomfortable, which is you could have just asked for his advice, right? Here's the problem. How would you think about fixing it? What are some principles that I can apply? But from my understanding, you actually invited him to come observe.
I think it was clear to him as well that as he was gathering data from his perspective and from understanding prostate cancer and management, it was important for him to see firsthand what challenges we were facing. And so he was kind enough to join me in my clinics and to listen to conversations and understand how we manage patients with prostate cancer. And it was from that experience that we started to develop and adapt many of the principles that he had obviously studied and used throughout his career. So he came to multiple clinics. I don't recall the number, but it was multiple sessions and trips to New York. And after each one of those sessions, we had a debriefing to really evaluate what he had observed, where opportunities there were to improve the communication in discussing risk. And from there, we moved forward and started to develop a standardized approach for discussing risk in men with prostate cancer.
You do this very vulnerable thing, which is invite them into your conversations. Having trained sales folks, it's the most high value thing and the most uncomfortable thing for sales folks to do, right? To invite a trainer or a manager into those conversations. It's often not invite. It's like someone is coming. It's like, my manager is going to ride along with me. You called for it. So he came with you. What was his initial feedback to you?
Many of the things that we had perceived as being effective were in fact not effective. At least in my training in medical school, there wasn't a class on discussing risk with patients. The experiences we bring to clinic are based on our own experiences, our own passions for healthcare, or empathy, or altruism. But there's obviously a formal academic approach that I had not appreciated, and he was able to bring to the table. And that's what really initiated us describing a standardized approach.
Can you walk us through what that prescription was, or what were the things that needed improvement? And then what was his prescription for how to make it better?
Another critical component of our team was Andrew Vickers, who's our lead in biostatistics, and Memorial Sloan Kettering, who is an impressive individual, very creative thinker, an expert in prostate cancer by himself. And between the three of us, we identified what's the critical intervention and how to implement it. Of course, the first step was to really adapt some of the principles in negotiation theory and behavioral psychology. But after understanding and developing an approach, it was Andrew's idea to create a standardized approach, because he was thinking 3 steps ahead, which is at some point this needs to be taught. So abstract ideas can't be taught without it being structured. So we realized that we needed not a script to speak to patients, but a step-by-step standardized approach about topics and themes that we want to at least explore. And so by creating that, it became an opportunity to later educate others on these techniques.
I gotta assume that that's fairly standard in the medical profession, right? I've read the checklist manifesto where pilots run through their pre-flight checklist to make sure that even though they've done it hundreds or thousands of times, there's still a checklist. If you're going into surgery, maybe it's in your mind, I'm not sure, there's probably a list of things that you check off as you get ready. So this is kind of applying the similar principles, right? If you're going to have an intervention conversation with the patient, this is taking abstract concepts and making it a step-by-step checklist of the order in which you walk through these things.
Absolutely. Even in surgery, many of our anatomic books and surgery textbooks are step-by-step how to do the surgery, techniques in surgery. So we're very well accustomed to seeing a standardized approach and using that as our launching pad to personalize it. And so we felt in a similar way, we can create an approach in communication.
And what were some of the principles that the team aimed to apply, and what was the recipe?
Initially, in every conversation, it was really get to the interests of the patient. It's oftentimes separating that from why they were there in the appointment. Oftentimes, cancer people perceive as just a choice between life and death. But in fact, there are interests patients have that it's important for physicians to explore. There may be factors in quality of life that are really important to patients. There may be financial consideration. There may be considerations of their family. There may be considerations of where they're located. So understanding and expanding the conversation from just, I had cancer, I need a treatment, to all these other factors helped us focus really into what was important for patients.
Dr. Ade and his colleagues came up with a new approach to talking to patients about prostate cancer and developed a standardized approach that other practitioners could use with their patients. They even created a laminated worksheet for other doctors to use as prep for their own patient conversations. And what's amazing to me is how universal a lot of these principles are. They're not just a way to communicate crucial information about treatment options. They're really great practical steps you can take to communicate better with anyone. Other principles. So one was to better understand the patient, to then individualize or personalize the care or the treatment options. What other principles ended up making their way into your recipe?
One was this concept of social proof. So people tend to do what others do. I felt it was good practice to tell individuals that despite the fact that most surgeons or radiation oncologists would prescribe treatment as either surgery or radiation, I'm recommending active surveillance as almost like a unique recommendation. But I didn't realize that in many cases that could be perceived as they're right and you're the wrong one. But I framed it within social proof. My recommendation, I would always explain based on our own data. So I would say, Mr. Smith, 90% of men just like you in my clinics would choose active surveillance. Based on national guidelines, all guidelines recommend active surveillance for men like you. All international guidelines recommend active surveillance for men like you. So now the conversation, instead of being, I am the unique person recommending active surveillance, they now are part of a larger group in which active surveillance has been the choice or right choice for them. So the second concept was this concept of anchor and adjust. We would get to the bottom of the time with our conversation, and in many cases, patients may have accepted that moving forward with active surveillance. And then they would say, what's the follow-up plan? And I would say, I'll see you back in 6 months. And it almost derailed the conversation because 6 months was perceived as a very long period of time. Well, my cancer can spread in that 6 months. And I realized early on that, well, we need to address that up front instead of at the very end of the conversation. So again, framing that within the natural history of prostate cancer, we now know based on studies done on men with prostate cancer who either were neglected or not treated decades ago, that changes in the prostate cancer may take years, sometimes 4 to 7 years to change to a more aggressive phenotype. And with screening practices that we currently employ, we're probably diagnosing cancers 3 to 5 years earlier than we would have if we didn't have screening practices. So based on that, many patients in their cancers may be safe to come back maybe at 3 years, but we want to watch them closely. So we want to see them every 6 months. And now 6 months becomes, in essence, like a bargain. It gets framed in the appropriate fashion related to the biology of prostate cancer and its natural history. Another theme was normalizing the experience. So we know that based on our data that many men and their families, when they start active surveillance, there's lots of anxiety. That's very normal. But usually about 18 months when we see those anxiety scores start to decrease. But it's important to address that up front. Many patients would say, well, I can see that 90% of patients in your practice are now choosing active surveillance, but I'm not that 90%. I'm anxious. I'm different. So instead of having that conversation at that point, we address it up front. So after my recommendation, I say, by the way, it's very normal to be very anxious right now. And you may become even more anxious when you get home, especially when you talk to friends, family. But know that that anxiety over time will decrease. And usually around 18 months is when you start feeling more and more comfortable. So that helped patients understand that this is what's expected, normalizing the experience. So these are just some of the tools we'd use and created in our standardized approach.
Is it right you used to order it differently than you did after their recommendation?
Correct. So one of the concepts in behavioral psychology is when you create a order, typically what you suggest initially, even though it could be just part of a list, is what's perceived as the one that's being emphasized. So as a surgeon, of course, when I started to discuss treatment options, I would start with surgery because that was what I was comfortable speaking to. And then I would talk about radiation treatment options. And then we would end on active surveillance. Well, I didn't realize by doing that, it almost made active surveillance feel like the least emphasized option. So I switched that order. I started with active surveillance initially. The other was this concept of recommending different from your perceived bias. Later, I found that many patients, when I spoke to them about active surveillance, they saw me as the active surveillance guy or the physician that does active surveillance. So I had to make it very clear that, no, I'm a surgeon and I'm recommending active surveillance. So before discussing active surveillance, at some point I would make sure to say, I'm a surgeon. I love to operate. I operate 2-3 times a week. I've been doing this for over 10-15 years. I've trained over 5 to 7 years to become a surgeon. But for you, I would recommend active surveillance. It's very powerful to recommend something that's opposite your perceived bias. We can't just prescribe what we think is the right thing. So understanding everyone's interest and bringing a solution that would be the best solution for everyone involved, all stakeholders in that conversation, is invaluable. So Absolutely. Beyond medicine, this has tremendous amounts of use case scenarios. And even beyond prostate cancer within medicine, there are many opportunities to continue to improve care with communication skills.
So, just to recap here for a second, get to know the patient, harness the power of social proof, anchor and adjust, normalize the experience, lead with your best recommendation, recognize your perceived bias. These are great tips for anyone, especially for people interested in being great at sales. And they're things you should be thinking about before you walk into the room to pitch, before you take the meeting, before you make the next call. Back in 2016, Gong Labs used AI tools to analyze transcripts from tens of thousands of sales calls to try to find out if there was a secret recipe to making a sale. What they discovered had come to be known as the golden ratio in sales, 60% listening to 40% talking. Put simply, that means that the top performing sellers listen more than they talk. And not just that, talking too much, especially more than 65% of the call, leads to lower conversion and win rates. This past year in 2025, Gong Labs went back to the data to see if anything had changed. Has the era of generative AI skewed the golden ratio? Turns out, the answer is no. The ratio remains the same, right around 60 to 40 listen to talk. But they did discover some new insights. Their most recent data revealed that consistency is key. The top performing sellers don't just follow the golden ratio some of the time, they do it all of the time. And I think most importantly, the best sales reps didn't just listen more. When they did talk, they asked better questions that encouraged participation. So let's talk about better questions and how they can help nail that diagnosis.
I think getting good at asking powerful, thought-provoking, deep questions is a journey that should last a lifetime. For me, the way I think about questions is what can I put out there that will almost stop them, create a moment of silence and space for the person to have to think about the answer. I do not want to ask a question that is really easy and quick to answer, because if it is, I probably could have figured it out myself, and I probably already know the answer. I'm just trying to get the other person to say it. So for me, a question's all about this rare opportunity to create a space of co-discovery with the person you're dealing with. And so, you talked about the diagnosing a problem. I think that's absolutely true. I'll take it up one level, which is co-diagnosing the problem. The skills I've learned as a coach are all around how do you hold the other person capable to solve their own problem. And the art of a good question is the beginning of a process to help them come to terms with what their issues are. In some cases, they might know clearly. In some cases, they actually don't know. And you have an opportunity to help them gain clarity on what their issue is. And so when I think of a question, it's all about allowing them to think about their situation. And you have a very intimate opportunity to hear their thinking. And there's so much from not only the answer they give you, but understanding the process they go through in thinking about the answer.
That's Shakil Barmal. He's a business and nonprofit leader with a long track record as a senior executive, consultant, teacher, speaker, and management coach. He's the founder of the coaching firm Ocean Blue Strategic, and he's also my colleague at the Ivy Business School. He started developing his sales skills at a really young age when his father, a new immigrant from Tanzania, opened a gas station. Shakil started working at the gas station when he was around 7 years old and continued working there until he finished his undergraduate degree.
Probably from the age of 7 or 8 and all the way up into university, probably most of my university time. My first degree, I worked there. As I got older, of course, I took on more responsibility. And so, I learned a lot about business, engaging with people, selling, building connection, watching him and doing it myself, practicing it myself. From the gas station world, I finished my undergraduate and I worked in oil and gas, in various aspects of oil and gas, more on the wholesale side, supporting a sales team. Super interesting from a human behavior standpoint. Supporting a sales team, helping them build credibility and get what they needed from other parts of the organization. I really got to see what other departments thought of sales, which is really super interesting for me. And then that evolved into a couple other positions in that organization. And then ultimately, I was a district sales manager. And then I went to Ivy. And then after Ivy, I joined a management consulting firm. I mean, that's the main reason I came to Ivy, was to go into that world. And I was super interested in working in different industries, dealing at the top level of organizations.
Shakil is also one of the most thoughtful people I know. He's someone who spent a lot of time thinking about what it means to ask good questions and how empathy can be one of the most important skills that we can have in sales.
The biggest contributor from all the varied roles I had, from the various levels and positions I had, it gave me the ability to put myself in many different shoes, to have what I like to call business empathy. So obviously empathy, dealing human to human and understanding what somebody's going through is really important, obviously, but serving so many different roles in so many different industries, dealing with so many different people, it gave me that extra layer of business empathy. It both allowed me to understand what somebody was trying to accomplish or what they were dealing with in their business or in their organization. Also allowed me to understand what questions to ask. And so combined with my business education and plus that real world experience in many different roles, it really did hone my business acumen and my curiosity for other people's businesses. Those things, both my personal desire to learn more and be curious and my understanding of business and how businesses worked and what business models were and how money was made, all those kind of helped me dive deeper and understand what, potential customers or people I was interacting with were dealing with.
You do a lot of coaching and have spent a lot of time in coaching. All of the best coaches that I've ever had often aren't giving you the answer, right? They kind of pull the answer out of you. How did you learn how to do that as a coach?
It starts with mindset. One of the things that I really had to challenge myself, and look, I took some brutal feedback from folks that were master coaches as I was learning. They said, when you are in a conversation with somebody and you're asking questions, really interrogate your motives. Are you asking questions or saying things so that they think you're really smart, so that you can build credibility in their eyes, so that you feel you are worthy of holding their time in the room? If that is your motive, then you're probably not serving them, you're serving yourself. As a coach, your whole aim, your whole goal is to serve them and it's their journey. The mindset part says, okay, what can I do to help them make progress, to help them learn something, to help them develop some awareness around their situation? And so you go in with that mindset saying, I'm actually here to serve them. And you have to believe that a person is served much better when they have a hand in defining their own path. So it sounds deeply philosophical, but you action that by asking questions that there may not be any obvious answer to on the surface. And so the more challenging, the more difficult, the risk that I find a lot of salespeople avoid taking is asking questions to which they don't know the answer. Back to that whole, am I here to serve myself and gain credibility in their eyes? Typically what you would do is you would never ask a question that you yourself didn't have something to say once you heard the response, right? Traditional selling is, let me ask a question, uncover a need, because as soon as I uncover that need, I'm ready with my solution to that problem. So salespeople that I've worked with and coached over time resist that asking questions to which they don't have an answer. The opportunity is to ask questions to which you actually have no idea what the answer is or what to expect. And actually, it seems counterintuitive, but that actually earns you more credibility in the eyes of the customer. A question that made them think, a question to which you weren't looking to sell them something. Wow, you're a different kind of person. You're different than most of the salespeople that come in to talk to me. When I think of an opening with a customer in a meeting, the objective of my opening is to make them feel like I've earned the right for their time. So I might start with a statement that says, last time we spoke, or I was talking to this individual, and I understand that you've got a really big issue in this area. So look, selfishly, I want them to think that I have some knowledge about their issue. That is a little bit of me building credibility with them. But I very quickly transitioned to, I don't know for sure, and I don't know what's underneath the surface of that. And I'd really like to learn more about your priorities and how you see this. And so not to throw it out, maybe out with the bathwater, it's still important to build credibility because they're also judging whether you're worth their time. Just spend just enough time there. It's usually less than you think.
When I think about questions that salespeople ask, they're almost leading questions, right? If I ask this, you're likely going to say this. So tell me all the things that you are unhappy about with your current solution. As an extreme example, say I am going into a meeting with somebody. How do you recommend people think about or prepare for what questions to ask in advance versus the ones that just come up on the fly?
Okay, so preparation for a conversation, I have a bit of an acronym that I use that comes from my it's not really an acronym, but it's a sequence of words. Them, us, fit, proof, next, them. Preparing for the meeting by doing a little bit of research or drawing on your base of knowledge around what might their issues be, given their industry, given their position in the organization, given other people like them you've met. What might their issues be? Is it revenue growth? Have you read an article in the paper that said this company's merged and this person's an HR role? And kind of what are the challenges of companies that are merged and are trying to integrate talent pools? Understanding what might be on their plate, 2 or 3 items that might be on their plate. That's your preparation. Without thinking about what you want to sell them, think about what is it that you might bring to the various topics that they might care about. Not the product you're selling, thinking more broadly around the expertise that you as an individual might have, the relationships you might have, the networks you might have, perhaps even the capabilities of your organizations that are not core to whatever you're selling. What expertise, what knowledge, what perspective can you bring to that issue? That's the us part. So them, what do they care about? Us, what do I bring? What do we bring to the table? Because I guarantee you have more potential to add value yourself as an individual based on your knowledge and connections and networks than your product has. So them, what do they care about? Us, what do I bring? Fit. Now, this is where you don't know the answer yet here because you haven't heard from them. But the idea is, how do I now connect the dots between what I know, who I know, the expertise I have, the capabilities I have? How do I connect those to the issues they just confirmed that they cared about, or the hypothesis I have on the issues they care about? If it's a first meeting, because in a first meeting, you might not actually know what really matters to them. It's really important to be humble and confident that I have some understanding of your issues, but humble enough to know, I don't know for sure that these are your issues. So that's the fit portion. How do I connect the dots between what I have, what I know, what capabilities we can bring to the issues? And then proof. Are there examples of places you've done this before? Are there proof points? Are there facts? Are there stats of impact that you've had? And then next, if everything goes well, what are you looking for next from them? What's your ideal outcome for them in this conversation? So if you can go into a meeting preparing that line, but then being very careful not to be stuck to the content that you've developed under there, because the conversation may go in a very different way. Preparing it, but sticking it in your pocket, and then starting just with them, and then going down the path based on whatever comes up in that conversation.
I love that. Them, us, fit, proof, next. Say I've done my homework. I come in with an idea of what the priorities are. I ask some I think about 2 or 3 thoughtful questions that I want to ask, and I'm digging. How do you know when to transition or when that topic is sufficiently explored?
To me, it's a bit of when your head starts to get full. So I do a lot of observational coaching with salespeople in kind of real play scenarios. There's a point at which they pretend they're listening, but they're not really listening. And the reason is because their head is already full with everything they've heard, but they're not stopping. They just let the person keep going. So for me, it's about how do you recognize when you've absorbed as much as you can, and you need to play back what you've heard to confirm you've understood. So that's a good gauge to say, okay, well, if just for a second here, if I can just kind of play back what I've heard you say, here's a couple things that I've heard you just say that are really important or that really matter or that are going on in your current situation. Did I get that right? At that point, the customer might say, yeah, you got that right, and just made me think of something else. So they will drive whether there's more to say on the topic because you've summarized, demonstrating, by the way, that you were listening, and you've opened the door to them to tell you something else. Or they might say, no, that's not exactly what I meant. And then there's an opportunity for them to clarify. But again, in both situations, they're driving whether we're done talking about this or not. Now, if they say, absolutely, yeah, that's about right, and they've nothing else to add, then you can say, okay, we've done that topic. And then you have a choice to make. Do you offer an insight based on what you just heard? Do you make some kind of commentary? Or you say, if you don't mind, I'd love to cover another topic. I mean, you're constantly making these decisions on the fly. That's why I don't think sales is easy. I think it's really challenging. And this is where you really kind of continue to work towards getting better and better and better. Why mastery is really hard to achieve.
It's time for the one thing. This week it's simple. Diagnose before you prescribe. Remember that patient who came to Dr. Aday asking for cancer treatment? Every other doctor had given him the same recommendation. But Dr. Aday asked a different kind of question. One he didn't know the answer to. What's really most important to you? Turns out it wasn't the cancer at all. And that changed everything. That's the power of asking questions you don't actually know the answer to. Not leading questions designed to uncover needs so you can pitch your solution. Real questions. The kind that make people pause and think. Because selling isn't just about chasing every shiny logo. It's about understanding the real problem and having the discipline to walk away when you're clearly not the right solution. You know, like the Fyre Festival. On the next episode of Sales Reframed, you've done the homework. You've earned the meeting. You've diagnosed the problem. Now comes the moment you've been waiting for. The pitch. Our next interview is with the man fortune called the marijuana billionaire. In 2011, Brennan Kennedy walked into rooms of buttoned-up investors and asked them to bet millions on the first cannabis company. And most people thought he was insane. He raised $140 million anyway and built Tilray into the largest cannabis company on the planet. And it all started with a story.
There's different pitches, right? There's a value proposition pitch. There's a product solution pitch or a product pitch. There's a problem solution pitch. But the best of the best tell a story.
That's next time on Sales Reframed. This has been an episode of Sales Reframed, and I'm your host, Eric Janssen. A huge thanks to my guests this week, Dr. Fyre Aday and Shakil Barmal. We've included links in our show notes so you can find more about the incredible work that they're doing. This podcast is brought to you in partnership with Ivy Executive Education. Part of the Ivy Business School, consistently ranked among the top business schools globally, Ivy Executive Education delivers high-impact learning experiences for organizations and leaders at all levels. From custom-designed programs to coaching and open enrollment courses, Ivy works with executives and business operators around the world to drive real results. Their mission, like ours, is to turn cutting-edge research into practical insights to help people learn, grow, and succeed in a changing world. This show takes a village. I'd like to thank our executive producer, Sean Ackland Grant, and our editorial advisor, James Greenhill. Our audio engineer and producer is Carol Eugene Park, and our narrative producer is Michael Catano. Thanks also to our creative directors, Christina Ball and Michelle Stanescu. Thanks for listening. We'll see you next time.